Hello, everyone, and welcome to the April meeting of the Global Health Youth Organization. My name is Noraldine, and I'm a co-founder of the organization, and we are very excited to see everyone who joined us today. We want to thank everyone for joining the meeting and working around any scheduling or time zone issues that you might have had. And for the format of today's meeting, we will begin with a quick introduction of our speaker, followed by her presentation, and then a question and answer session. After the Q&A section, we will be posting the shadowing certificate link in the chat, and we ask that all members stay muted throughout the presentation so that we can limit interruptions and distractions. And please feel free to add any questions or comments that may arise in the Zoom chat. And I'll now be passing it over to Adam, the other co-founder of the organization, to introduce today's speaker.
Thanks, Nor. Hello, everyone. And as Nor mentioned, I'm a co-founder of the organization. It is so great to see all of you that joined, and we're so happy that you're able to attend this meeting. We want to once again thank Dr. Sonia Bansal for taking the time to present today. To quickly provide an introduction, Dr. Bansal is a neuroscientist and faculty member at the University of Maryland School of Medicine, where she's involved with studies on cognitive and perceptual deficits in schizophrenia. Please remember to stay muted throughout the duration of the presentation to minimize distractions. Again, if any questions do arise, please type them in the chat and we'll get to answering them at the end of the presentation. With that being said, we will now hand the floor over to Dr. Bunzel for her presentation. Thank you.
Hello, everyone, and welcome to this presentation. Thank you for joining. Before I begin, I'd just like to thank the organizers for having me, and I think they're doing a great job with this forum for all the youth. So welcome, and hope you enjoy the talk. I'll just take a minute to share my screen first. All right, can everyone see that okay? Just give me a...
Yeah, we can see it.
Okay, great. So today's talk, I'll basically give an overview of schizophrenia, its symptoms, some of the causes, treatment, and get into a brief overview of some of the research advances. So with that, I'll just jump straight into the outline. So I'll start with what schizophrenia is. I'll go over some of the symptoms, the etiology, which is basically some of the potential underlying causes and course of illness. And then, as I mentioned, I'll get into some recent advances in understanding schizophrenia and briefly go over treatment. And if there's any resources I can help with, I'll leave my email address for that. Before we get into all of that, I just wanted to take a minute for you all to kind of respond to this poll on when you hear the word schizophrenia, what do you think of? Adam or Nor, is there a way you can copy that poll into the chat?
Yeah,
I'll just type it into the chat right now.
Okay, perfect. Actually, let me see if I can do that. There we go. Oop. Anyway, it's pollev.com/Sonia Bansal 405. So hopefully we'll see some responses here and we'll get to know what you guys think of. I'll give that a couple minutes. There we go. Great. Feel free to add up to 2 responses. All right, we can end there. It seems like we've gotten quite a few responses. As you can see, when people hear the word schizophrenia, one of the most commonly perceived words is voices, hallucinations, mental disorder, illusions, and so forth. So basically in this word cloud, the most commonly indicated word is in the biggest font. So that's what kind of we see. We can go ahead and stop responding, but you see that that's pretty much the perception of the illness. But in fact, it involves a lot more than just those. Those are just what is possibly portrayed in pop culture or just the stereotypical classic patient presentation. But I'll get into what the symptoms actually are, and it's a pretty wide range besides the commonly heard of ones. So basically, schizophrenia involves major disturbances in thought, emotions, and behavior. There's a lot of disordered thinking, where ideas are not logically related. There's faulty perception and attention to external stimuli, and a lot of lack of emotional expressiveness as well. And there can be disturbances in movement or behavior as well. And with all these symptoms, it can obviously disrupt interpersonal relationships to a great degree and diminish the capacity to work or live independently. And unfortunately, schizophrenia has elevated rates of suicide and death as well. As indicated on the slide, it impacts about 1% of people. So 1 in every 100 people may possibly have schizophrenia. And it affects men slightly more than women. And in men, the onset is late teens to 20s. And in women, it's a little later, 20s to early 30s. And I'll get into the detailed description of the symptoms, but they're basically divided up into 3 different main symptom types: positive, negative, and disorganized symptoms. And the symptoms vary a lot, although there are some common signatures. And about 75% of schizophrenia patients will have some sort of functional disability over long term. And in my research setting, we definitely see that. So I'll get into the symptoms now. So as I mentioned, each person's experience with the disorder will share some common themes with other people who have the same condition, but so many aspects of the disorder and its path are often unique as well. But over time, experts have separated these symptoms into the categories I mentioned. So positive, negative, disorganization, and also cognitive symptoms. So positive symptoms is basically kind of the presence of something extra, thus positive. So these include things like you all mentioned: hallucinations, delusions, thought problems, and movement issues. So hallucinations are basically sensory errors where a person thinks they can hear, see, smell, or taste things that are not present. And delusions are strong beliefs about people or things that are unrealistic or not necessarily supported by actual facts. And in terms of disorganization or thought problems, these are different from delusions in the sense thought disorder is basically someone being very disorganized, stopping their train of thought, or making up new words. And this is commonly known as a word salad, where words are just kind of tossed together like a salad. And there's been some, if we have time, I'll give you some examples of this with patients I have seen. And then there's negative symptoms, which is basically the absence of something at normal or baseline levels. So these include things like feeling flat or just reduced reactions, reduced emotions, feeling less pleasure or happiness, or being less sensitive to rewards, and problems completing expected behaviors. And also we see quite a bit of lower volume of speech, so just speaking less often or not being expressive as well. And then in terms of cognitive symptoms, there's a diminished ability to think, to understand certain issues, to not being able to make choices, as well as disability in staying focused or paying attention to things, and memory problems as well. So that's kind of a big picture, but we do have variability from patient to patient. So again, this is kind of going over what I described, but presently, most treatments are geared towards just the positive symptoms, so reducing hallucinations and psychotic symptoms like delusions and such, even though there have been some interventions and development for cognitive symptoms and negative symptoms as well. Most of the efforts are geared towards positive symptoms. And those are, even though they're the most kind of prominent and most observable, cognitive and negative seem to impair functional outcomes to a greater degree. So now I'll get into the etiology, just discussing various factors that can contribute to the development of schizophrenia. So the focus has mostly been on genetic predisposition, but there are environmental and social factors, things like childhood trauma and abuse, just things like facing a traumatic life experience. And then there's neurodevelopmental abnormalities that both of these two factors feed into. And these abnormalities include possible brain damage, pre-birth, or certain neurological features within the brain that are abnormal as well. And then all of these also feed into brain dysfunction in terms of improper balance of chemicals. And I'll get into that in a bit. But that's pretty much where the treatment targets. In terms of genetic factors, so it's pretty heterogeneous. There's no specific single gene that causes this, but there have been family studies where relatives are at increased risk, and then negative symptoms have a stronger genetic component, it's been found. And there's also been twin studies where there's a much more elevated risk for twins, for monozygous versus dizygous twins. And children of non-schizophrenic twins were also more likely to develop schizophrenia. There's also familial high-risk studies where, basically clans of families have been examined and risk has been assessed in those studies. And at the very lowest level, there's genetic studies involving certain polymorphisms in the genetic makeup, and there's very few genes identified so far. So those two genes are basically associated with cognitive and negative symptoms. And I'll get into this a little later, but more recently, there's been genome-wide scans inspired kind of by the Human Genome Project. This also trickled down into clinical applications, and there's been more progress on that. But yeah, I mean, I think currently in terms of etiology, the biggest focus has been genetic predisposition. And then in terms of pathophysiology and how the brain's affected at kind of the neurochemical level, there are three kind of major hypotheses. And the oldest one, which has been held for a long time, is the dopamine hypothesis. And the focus here is on the mesolimbic pathway that affects positive symptoms. So with the mesolimbic pathway, that's involved in reward and pleasure. So it affects reward, pleasure, emotions, and affect as well. And that's also true for the mesocortical pathway, but that seems to affect more reactivity to emotions and affect. And then this last pathway, the nigrostriatal pathway, is involved in motor movements. So But the emphasis in terms of the history of the dopamine hypothesis has been the mesolimbic pathway. So with the dopamine theory, it's proposed that the disorder may arise due to excessive levels of dopamine in that pathway, which results in positive symptoms or even in some cases aggression. And the reason that was proposed is that certain drugs that alleviate symptoms reduce dopamine activity. So it was kind of a reverse theory. And then other sets of drugs like amphetamines, which increase dopamine levels, result in psychosis, even in people who don't have a history of psychosis. So with those two facts, this theory was formed, and that whole section is kind of content for a whole another 2-hour long lecture, so I won't get into that, but you can email me with questions if you'd like. And then later on, as the theory developed, they also found out that excessive number of dopamine receptors or oversensitive dopamine receptors were found in the brains of schizophrenia patients. And also underactive dopamine activity in this second pathway resulted in hyporeactivity in terms of symptoms, so thus leading to the negative symptoms that I described. And then the other two hypotheses, the glutamate hypothesis is more recent. This was again based on observations that certain drugs could induce a full range of psychotic symptoms in normal subjects. And in terms of actual brain pathophysiology, as I mentioned, there may be certain damage to the brain, like loss of gray matter, smaller volume, enlarged ventricles, and loss of function in terms at the neuronal level. But again, each of these can be a lecture or two on their own, but I'm happy to take questions about this later. So this is kind of a picture of what I basically described, injury and then dopamine neurons underactive and excessive activity from dopamine neurons resulting in positive symptoms of schizophrenia. But that said, this theory doesn't fully explain the disorder. Symptom relief takes weeks when antipsychotics that block dopamine are functioning. And to be effective, these antipsychotics actually need to reduce dopamine activity to below normal levels. So, it's still in the works, and the other neurotransmitters involved, like the glutamate hypothesis, that pathway is being investigated more so for drug development as well. And then I'll now get into just an overview of recent advances in understanding schizophrenia. So as I mentioned, the genetic component is a big one, and spurred by the completion of the Human Genome Project, attention was turned to sequencing and identifying genetic variations related to the disease. So it has been established over the years in various smaller studies that schizophrenia has a genetic component, but only recently there has been more studies involving a lot larger sample sizes that can be examined to identify common variants of certain genes. So, as of now, 8,300 single nucleotide polymorphisms have been identified that contribute to overall risk, but that's still quite a bit. It's hard to narrow that down. And with other studies, there's also been overlap between risk for schizophrenia as well as risk for bipolar disease or autism. So there's a lot of overlap with some of these other neuropsychiatric disorders. And so I mentioned the genome-wide association studies, and I mentioned that the genomes of people from similar backgrounds are sequenced at a large sample size, and using various computational and bioinformatics methods, they're compared to each other, and clusters of commonalities are found. And this is possibly, in some studies, these clusters are kind of tested using behavioral tasks or neuroimaging studies to assess the level of impairment as related to the genome sequencing. So that's a big one in terms of advances in research. And then off late, computational psychiatry has taken off to a great degree in the past 10 years or so, probably longer, but has come to the forefront recently. And it basically leverages some of the neuroimaging and behavioral findings to use machine learning and improve outcomes for patients suffering from the disease. So it uses both data-driven and theory-driven efforts, in the sense using already existing data from patients who are suffering from the disease. They can form kind of clusters and target treatments accordingly. And in terms of theory-driven efforts, various computational theories are put forth in terms of trying to explain the symptoms, and again, leveraging various methods like neuroimaging and basically other assays of either brain function or behavioral function. And again, each of these is beyond the scope of this talk, but I'm happy to answer questions about any of them. And then in terms of treatment, some of the recent advances include non-invasive brain stimulation. So an example of this is transcranial direct current stimulation. So it's basically a method for modulating neuronal activity by introducing a small current to certain localized brain areas using electrodes that are placed on the scalp. And so far, there's been some pretty good progress in improving, or rather reducing, auditory hallucinations using this method. So basically, auditory hallucinations, as some of you put as the words you think of, is hearing voices and sounds that may not be there. And then with that, I'll get into my area of research. So I basically study cognitive function and perceptual function. So perceptual function includes more of the positive symptoms, hallucinations, illusions, delusions. And cognitive function includes things like memory loss, inability to focus or pay attention to things. So in spite of it not being given as much attention, it's a core feature, and it precedes the onset of some of the other symptoms, and it can be predictive of outcome, and it's easy to test in the sense you can assay the neural systems involved by just conducting some experimental tasks while the brain is being brain activity is recorded in a neuroimaging scanner. It could be a target for treatment development. So there has been some drugs that are used in Alzheimer's disease that can target some of the impairments in schizophrenia as well. And it can be used as a prognostic indicator, which is basically measurements available at the time of diagnosis that are associated with a disease-free or pre-presentation of the disease state. So those factors can be used to predict the natural history of the disease. So, in my opinion, this is an area that could be leveraged to a much greater degree than it already is. And that's kind of my area of work in terms of looking at some of these cognitive disabilities. But again, feel free to ask me more questions. This is a brief overview. And then in terms of treatments, there's been a history of development of some of these antipsychotic medications. So in the 50s, there was antipsychotic drugs that reduced aggression, violent behavior. And this was again based on the dopamine theory that, the excessive levels of dopamine in the mesolimbic pathway. So these drugs block the dopamine receptors. However, they had little effect on the negative symptoms of the disease, had a lot of extrapyramidal side effects. So these are basically side effects related to nerves concerned with motor activity that descend from the spine, but are not part of the main pyramidal system. And so it took a lot of extra doses to prevent a relapse. So these kind of drugs faded over time, but currently we're using second generation antipsychotics, which have fewer motor side effects, less treatment non-compliance because patients are more likely to take something that gives them less side effects. However, with any kind of strong antipsychotic medication, there are some side effects, including dizziness and weight gain. Weight gain is something we see a lot in our clinical research center. And currently there is concern about psychotic patients being more prone to catching COVID or having worsened symptoms of COVID because of immune function. And then there are some meds, as I mentioned, that could be used in other disorders as well that improve cognitive function as well. And in terms of psychological or non-pharmaceutical pharmacological treatments, there's various kind of therapies that are used. So there's therapies geared at improving psychosocial function, social skills that include improving interpersonal situations. And some of these involve role play. And recently, they've started using virtual reality to help some of these therapies, which is kind of cutting edge, but still in the early phases. And family therapy is a pretty important piece. There's stressing importance of things like meditation, mindfulness, helping family to cope with a member that may have schizophrenia. And cognitive behavioral therapy is something that all psychologists and psychiatrists are trained on in terms of recognizing certain symptoms and personalizing the therapy to help patients recognize and accept and cope with those symptoms. And similarly with cognitive remediation training, that improves things like attention, memory, problem solving, and other cognitive symptoms. And then there's case management and residential treatment, which is standard for a lot of neuropsychiatric disorders. And that's pretty much it in terms of treatments. In terms of future directions for research or treatment, so a lot of emphasis currently is mostly on the pharmacological treatments. There needs to be a combination of evidence-based psychotherapy modalities as well as pharmacology to work together to improve the outcome of the disease. And in terms of using genetics, a lot of the diagnosis is still symptom-based, but we have a lot of data on genetic and neurobiological overlaps between many disorders. So, future classification of these illnesses may need to move towards more genetic-based, biologically based dimensions. And along those lines, the NIH, the National Institutes of Health, has actually put forth a research domain criteria framework where researchers are encouraged to look at symptom groupings or brain dysfunction in terms of clusters versus just looking at it as just the diagnosis based. So that's kind of on a spectrum, looking at symptoms on a spectrum. So that's hopefully will inform parts of bullet number 2. And then using neuroimaging findings to translate to the clinical setting in terms of either diagnosis or looking at the efficacy of antipsychotic treatment. So with that, I think that's mostly what I have. I am open to questions and happy to go back to anything I may have mentioned.
Sure. Thank you. Thank you so much for the presentation. It was absolutely amazing. So if it's all right with you, we'll first start with the questions that were asked through the registration form, and then we'll get to any questions that were asked in the Zoom chat.
Sure.
And for everyone here, so this is your opportunity to ask questions. So please ask whatever you have in your mind. So I'm going to hand the floor over to one of our board members, Mark, to read the questions that were asked through the registration form.
Mm-hmm.
Thanks, Adam. So the first question that was asked was, how did you find mentors to guide you, not just on the medical path, but through neuroscience as well?
Yeah, so actually I'll go ahead and stop sharing, but I'm happy to go back to a slide if need be. So yeah, in terms of finding mentors, I think it mostly began during college, just by taking certain classes related to my major. I found out more about the research side of things and reached out to certain professors or my neuroscience advisor and asked if there was research opportunities and got research mentors accordingly. And I think in college there's, there's a lot of people willing to help develop your path towards grad school. So in college, you usually have an advisor. That's the first person I would suggest turning to. At the high school level, getting involved in programs like this would be great. You can connect with speakers. You can connect with other students who may have research opportunities that they're involved in and gaining mentors accordingly. And again, I mean, thanks to the internet, there's a lot of advertised summer programs for high school students. And, as you look into college majors, you may seek out these opportunities according to what you're interested in.
All right, that was well explained. So the next question that was asked was, is a neurosurgeon and a neuroscientist the same? Could a doctor participate in neuroscience research? If both are different, then what are the differences?
Sure. Yeah, so they are very different. A neurosurgeon basically goes through med school and then gets into the specialty of neurosurgery. And the purpose of a neurosurgeon is mainly to treat, brain disorders that involve invasive surgery and correct certain things, and deals with the nervous system as well. So it's very much at the neurological and brain function level. With neuroscience, you're studying brain function as it relates to behavior. You're looking at the neural underpinnings of certain behaviors. And these neural underpinnings may be basically at the, looking at certain brain pathways or even at the molecular level. So a lot of neuroscience involves inquiry into brain function, whereas neurosurgery is almost fully treatment-based. However, that said, a neurosurgeon can certainly work with neuroscientists to study brain function in general. So for example, in terms of brain function, studying patients with brain lesions or people with split brain disorder, you would definitely need a neurosurgeon to guide that inquiry. So it in terms of research and just studying the brain function as a whole, neurosurgeons can definitely be involved.
It's an interesting answer. So the next question is actually somewhat related to this question. And it's, have you ever had any experience in neurosurgery yourself?
Not on humans. I have done some animal models of psychiatric conditions in which I did perform surgery on mice and rat brains, but that's at a very low level compared to neurosurgery in humans. So basically, I studied certain neurochemicals that can cause plaques in the mouse brain, plaques similar to what is seen in Alzheimer's disease. So there was surgery involved in terms of getting brain slices and looking at the brain histology. So the molecular and brain function with mice brains. So no human neurosurgery for me, thankfully.
All right. The next question is it true that dopamine abnormalities in the mesolimbic and prefrontal brain regions exist in schizophrenia patients and tied to hallucinations or delusions?
Yeah, so I think I touched upon this in the talk. Yes, elevated dopamine levels can lead to positive symptoms like hallucinations and delusions. So the function, as I mentioned, was discovered due to the effects of the drugs and due to the recognition that amphetamine elevates psychotic symptoms in non-clinical people as well. So that's basically the effect of elevated levels of dopamine in the mesolimbic system. But as I mentioned in the talk, there are the other systems and neurotransmitters involved as well.
All right, thanks for that answer. So the next question we have is, as a cognitive neuroscientist, do you have any tips for anyone going into the field and studying neuroscience?
Sure. I mean, I think from my experience, looking out for research opportunities at this level would be great. As you get into college, same thing, research opportunities, and of course, relevant coursework, but that's something your college and program will guide you through. But at this level, the most you can do is research opportunities and seek mentors and find people that, if you're interested in the kind of work they do, definitely email them, reach out to them. I, as a faculty member, in my personal experience, I'm always happy to get interest from younger people interested in the same things. So I think communication is key, reaching out to people you're interested in and again, programs like this really help. So I think so far you all are doing what you should be doing, I think.
All right. So yeah, thank you for that. The next question we had down was, has learning about how our minds work changed your views on life and our existence? And if so, how?
Wow, very philosophical. Thank you for that. So I think it has, in the sense, the brain's such an intricate organ. There's so much function involved. And the fact that using technologies, we can study it, we can mimic it, and yet we don't know much about it. So that's pretty eye-opening for me. And in terms of specific research with clinical populations, I think it makes me appreciate my own cognitive function to a greater degree and recognize, the various ways in which our brain affects behavior. So it's very eye-opening and it's very inspiring in the sense the brain is so fascinating. There's so many functions involved. There's so much we can learn. And yeah,
I think the appreciation aspect that you talked about was phenomenal. I think I personally wouldn't have thought of that. So I think that's a really cool aspect to think about when you think of what, studying the brain has taught you in a clinical setting.
Yeah.
Thank you for that. The next question we had down was, why did you focus on researching schizophrenia and not other disorders?
So I think during my undergrad days, I got involved, as I mentioned, with the animal models of certain disorders. So I knew I wanted to get into neuropsychiatric disorders in general. And as I got more research opportunities, I realized I didn't really want to study animal models or non-human primate work. I didn't want to work with that. I didn't want to torture poor animals. But I was still interested in brain function and the underlying basis of certain symptoms associated with neuropsychiatric disorders. And I think in terms of, so the various methods I used led me to studying schizophrenia to a greater degree than other disorders, just because with certain brain pathways, not much is known, and that was what I was interested in. And again, with schizophrenia, it's one of those neuropsychiatric disorders in which, even though there's so much variability, there's nothing specifically pinpointed about the underlying cause. So I'm hoping to contribute towards that with my research interests. So
It's cool to hear how you originally started with the animal neuroscience. So that's cool. It's interesting to hear. So another question kind of related to schizophrenia. Are there any challenges during researching schizophrenia, and how did you approach these challenges?
Yeah, I mean, I think in terms of clinical work and working with patients, that's always a challenge. You never know how they're able to perform experimental tasks, and there's compliance with medications. There's certain technical difficulties that may arise. So there's that aspect that needs to be dealt with. And then again, in terms of on a theoretical level, it's hard to establish, certain proposed theories to a certain degree because not much is known about certain things. So, I mean, that's a good and bad thing. Like, it's exciting to not know, but at the same time, you need to leverage what's out there in the literature, and kind of combining the two is satisfying, but still a challenge.
All right, thanks for that answer. So this is the last question that we have from the application form.
Sure.
And it says, can nanotechnology change how schizophrenia affects the brain?
So I think in terms of nanotechnology, that's probably a good use for developing or improving pharmacological treatments. So nanoparticles, just by virtue of the small size and easy delivery into either bloodstream or nervous system, can aid the function of pharmacological treatments. In terms of changing the underlying brain function and changing the course of illness, not directly, but by aiding the delivery of other pharmacological treatments, I think so. And nanopsychiatry is actually an upcoming field where they're looking at drug delivery enhancement through nanoparticles. So that whoever asked that question, you can read more into nanopsychiatry.
All right, perfect. So now we'll go on to the questions that were asked in the Zoom chat just now. And so the first question that we have down was, how has COVID-19 affected your current work?
It has. It's been a bit slow in terms of implementing some of the experimental tasks because capacity in research centers has been reduced to a certain degree, and we're not able to bring as many patients in. And I think, just developing a research plan during COVID has been a challenge to begin with, in terms of just organizing the staff, in terms of organizing sanitizing equipment, in terms of leading teams where some members of the team may not be comfortable interacting with patients at this level. And more recently, I think, not specifically for me, but people who do outreach in some of these clinical communities, one of the challenges is to keep patients informed about vaccines and reduce their hesitance in taking them. So just outreach in terms of education about vaccines. So that's, I think, the newest challenge.
Yeah, I'm sure those are challenges. A lot of people, especially in the medical field, have had problems. A lot of our speakers have had problems with COVID-19 affecting their work or their research. So perfect answer. So next question we have was, how likely is it for individuals that have schizophrenia to exhibit bipolar symptoms or to have bipolar disorder?
So that varies. We do have comorbidities. So comorbid disorder is something that goes along with another disorder. So a specific diagnosis is schizoaffective diagnosis, where people have psychotic symptoms, have certain traits of schizophrenia, but they also have an affective component, which is similar to bipolar disorder. So that on its own is a separate diagnosis. And then there's people, so I would say that a lot of people who may have had bipolar with schizophrenia get diagnosed as schizoaffective. There is some overlap in kind of the prognosis, and someone may start early with bipolar but get a psychotic component. So then those are diagnosed as bipolar disorder with psychosis. So there's the course of illness as well as symptom overlap dictates the diagnosis of this. In terms of how common that is, it's hard to say. It depends on age. It depends on just the course of illness as well. I don't have the exact stat for that, but I'm happy to send that to whoever's interested.
All right, thank you for that answer. Next question we have down is, how do you feel about how pop culture or the media often portrays schizophrenia, and do you think these stereotypes are damaging?
So in terms of pop culture, I think there's a problem in general with just how mental illness is portrayed, not specific to schizophrenia per se. But I know there's a misconception that schizophrenia is split personality disorder. There's certain misconceptions about anyone who hears a voice is schizophrenic, that kind of thing. In terms of true stories or like biographical accounts of this, the movie A Beautiful Mind gave a pretty close to accurate picture about the disorder, in terms of showing, hallucinations, in terms of showing the paranoia component. But I think, as with all mental disorders, a lot more outreach and education needs to be done. I'm just going to share my screen a second because I see in the chat people asking for my email address. So I'll just put it up here. There we go. Hopefully everyone can see that.
Yeah, we can see your email address. Thank you.
Okay, great.
And I think that's all the questions that we have. If anyone else has any questions, please feel free to write them in the chat. All right, so we're going to end this presentation off. I'm going to hand the floor over to Noor really quickly to provide the ending part of the presentation.
Yeah, and thank you so much for all those amazing answers. So we would once again like to thank Dr. Bansal for taking her time today to give us an introduction to some of the most advanced research in schizophrenia. And thank you all for attending today's presentation. We will be posting the link in the chat to obtain your shadowing certificate for the hours that you've been attending here. And thank you all so much for attending, and we look forward to seeing you in our next monthly meeting. And we'll be providing more information about that in an email coming out today. And we'll stick around for a couple more minutes to make sure everyone has access to the link. So if you have any problems, please let us know.
All right, thank you everyone. It was great being part of this. Have a good weekend.